Moshi Moshi. I'll have to edit this one. All right.
Oh yeah.
Moshi Moshi, let's talk about the future. I'm Christy Bird McKeeve, CEO and founder of Evergood podcast, and we're going to talk about healthcare, education, innovation, three words that don't normally show up in a sentence, but here we are. And a lot of the work that the people that I bring onto this podcast and I work focus on is really bringing hope for communities, really diving into how to address access to care, as well as economic development. They all kind of go hand in hand. And today I'm very excited, Dr. Donaldo Hernandez, and I'm going to try to introduce him as best I can because I know him as the past California Medical Association president, current board member for Physicians for a Healthy California. You're also very active with both the Santa Cruz Monterey Medical Association and its foundation, I believe, which is now called Physicians for a Healthy Central Coast. So, and you do so much more. So what are the hats that you wear?
There's many. You're right. Um, so I'm a practicing internal medicine physician in hospital-based medicine. Actually a fellowship trained hospitalist. Got trained back in the early '90s when that word didn't really even exist. And so I've been involved in hospital-based medicine for a very, very long time. And so I'm based in Santa Cruz, which is I call it a transitional zone between the urban and suburban areas of the Bay Area and the agricultural South Central Coast. The largest employer in Santa Cruz County is agriculture. Strawberries, berries, apples, you name it, it's grown here. And it opens ourselves up also to the other parts of the agricultural Central Coast in San Benito County and Monterey County, a lot of row crop. And so we have a large farm worker population, agricultural worker, as I call them, essential agricultural workers. And as a consequence of that, and the work that I've been doing within basically healthcare reform and healthcare finance and policy, I'm also a commissioner for the Central California Alliance for Health, which is the community-operated health system for Medi-Cal for Santa Cruz County, Monterey County, San Benito County, Merced, and Mariposa County, a stripe of counties right across the middle of California. So when I talk about living in Central California, I do. Um, Again, very agricultural. If you think about those five counties, ag comes right to the top of your mind, and the people that live in our cities in our region are very they're populated but surrounded by large areas of agricultural land. Think about Merced when you think about Hollister, Salinas, and all the valleys, the cities in the Salinas Valley. It is, there's tourism here too. You think about the Monterey Peninsula and you think of the boardwalk here in Santa Cruz. There's tourism that exists here and the hospitality industry. Pebble Beach, of course. But the thing that drives this region is ag. Um, and so I have a bit of knowledge when it comes to Medicaid and the effects of recent changes in Medicare and Medicaid funding, um, and the challenges that those communities exist. And one of the things I think the thing I'm most proud of here in California was Proposition 35, which was on the November ballot, which was a methodology by which we could increase access to providers in the community. Also shoring up our emergency room and our you know first responders and making sure that they were adequately funded. Medi-Cal, which is the Medicaid product here in California for years and years and years, was really underfunded with respect to the provider side and ability for the providers to see that population of patients in a way that allowed them to at least even get close to what the cost of providing care for those patients even approximated. And so Prop 35 was designed in a way to increase that access by aligning the actual cost of care closer to what you get paid for to see those patients.
Yeah.
Um, what drove that was largely the experience we had during the pandemic. And with respect to Santa Cruz County particularly, it was two zip codes in our most agricultural area of the county that resulted in over 70% of the admissions to hospital relative to complications of COVID. And those were the chronically under-resourced communities, the agricultural communities, multi-generational communities. And what became very, very clear to me as we sort of drove through what was going on was those were communities that couldn't work from home. They couldn't distance themselves. They weren't in tech related or other sorts of industries that would allow them to be able to work remotely. They fed us. They went into the fields. They provided the sustenance essentially for us. And as a consequence of that, they suffered for it. And so really starting to think about what that really translated to in terms of access and frankly, equity, in my opinion, was the ability for them to actually access physicians where they lived in a community-based setting and trying to move the needle away from getting their primary care in emergency room settings because they didn't have medical homes. They didn't have a community-based opportunity to see doctors and to see clinicians where they lived and in an environment that they could see them. And it made more sense for us to try to see if we could shore up that part of the delivery system. And that's what Prop 35 was all about. And the fact that it passed in almost every county in the state of California with 66, 67, in some cases 68% margins meant that the state of California and the people and the voters of California understood that you cannot, to have a system of delivery that works for all, you can't exclude some.
Yeah.
And it became very, very clear to me, and what I was very, very proud of is when we articulated that message, people understood that. And that will be the highlight of my career for I will go I will go to bed or to go to my rest eventually, long time from now, I hope. That as having that as my proudest accomplishment. Now, obviously, that's changed because of the methodology within the latest changes coming out of Washington with respect to provider taxes. But the idea and the notion of what it was supposed to do and why I still think it's a valid mission statement is the provision of care for under-resourced communities affects care delivery for everybody in the community. And we saw that time and again, and we still see that. So fully resourcing the delivery system becomes incredibly important. Another part of that, which was really important, I think, to the context of this conversation, was the funding of the graduate medical education
Yes.
and understanding that, yeah, exactly, that the statistics throughout the state, but particularly here on the Central Coast, we're going to lose probably over a third of our physician workforce in the next 10 years, and we're not replacing them.
Yeah.
That workforce crisis, particularly in an environment where the largest group of patients, at least here, and I would think statewide, is the population over 65, that Medicare population. That population is growing as baby boomers age into that and now populate that demographic within the state of California in a very large way. So being able to have physicians to care for that population is going to become incredibly important. Really important in the under-resourced and rural areas of the state where we already have a provider and physician deficit, I would say relatively. So understanding that expansion of graduate medical education opportunities really was one of the bedrock concepts of Prop 35 as we went forward, and understanding that investment in my replacement and the replacement of many of my peers it is absolutely important to the well-being of the state as a whole, and continued investment in medical schools and the expansion of medical school opportunities and
Wasn't
GME.
wasn't that a part of Prop 35 was also in a couple of years was to also expand into UME
Yes,
funding? Yeah.
right. Because and that was again understanding that what we really were trying to be was flexible in what the needs of the state really were. And we understood California needs more medical school students, full stop. California is the next net exporter of medical students, full stop. We recognize, and the data shows over and over again, that individuals if they train where they live or they train in a place close by where they live, and that includes medical education, they tend to stay in California. I was educated at the University of California, San Diego. I did my residency at UCLA, and I came to the Central Coast because I'm bilingual and bicultural, and I understood that there's a large Latin population here that could be served by somebody who understands and is culturally competent in their needs. And I think I've continued to try to do that while also being a hospitalist, trying to get overlap those two parts of the Venn diagram. Um, but the notion of having California grow its own physicians and train its own physicians and having those individuals be of California and of the communities of California, absolutely vital and was mission central in Prop 35 and all the work that we've done since.
I think of California, I hope, or I have a vision of this for the future, that it's the destination for medical education, that across the country, there's great medical schools in most states, and wonderful residency programs. But my vision would be that we're known as the, you know, leaders of science, medicine, and public health, and those are key ingredients for a solid medical education. So I don't know. I think big, and I know you do too. But we're
Yeah.
kind of in that place. I Googled this the other day. What's the state with the largest number of medical schools? And I think we're second in California. And so we just need one or two more to be the leading state.
No question. And that's where the innovation comes in, right? Start, what is medical education when you think of it? And I think it's a broad definition.
Yeah. It's such
We
an
have,
incredible
like,
degree too that can lead in so many different directions. MD and DO, like
absolutely,
research. I mean, it goes in so many different ways.
no question. And that's the thing that I think medical education really allows us if we build it the right way. I think, I mean, like you said, I think about the biomedical research that's going on throughout the state in San Diego and in San Francisco and elsewhere. But I also think about epidemiological research that goes into communities and actually looks at communities and really understands what those communities need and try to provide, competent care in a way that meets those communities' needs. I also think of, just your physician sitting down at a bedside with somebody or in an office and talking about the complexities of care delivery. We're in a world right now where medical authority and medical expertise is being questioned.
Yeah.
I don't need to remind everybody that we're in a period where people are distrustful of things that have been bedrock in terms of medical understanding. And I'm talking beyond just vaccines. You know, why do we use this medicine? Or why, just the other day, I was reading an article that came out of the European Cardiac Conference about the use of beta blockers in people that have had congestive heart failure and their efficacy. And that's been a bedrock principle for a very, very long time. And now that's even being thrown into question, but in a way that really makes sense because we're re-examining, medical research is re-examining things that we thought were canon, realizing, no, there's nuance there. For some patients, it's an absolutely important thing. But if you paint with too broad a brush, there are some patients for whom that therapy may even be detrimental. And so that's medical doctors, that's physicians looking at that again and again and going like, you know what, let's re-examine this data and really start honing in on the fact that we're going to develop care that's very tailored to the individual issue. I think of oncology. We're at a point now where people that have cancer diagnosis are going to be able to get care catered specifically to their genetics, specifically to their cancer, specifically to their kind and the degree of their cancer. It's going to get to the point where they're going to know your genetics, know what's wrong with your genetics, and be able to go in and treat your cancer in a very individualized way. Unheard of 10 years ago. But we're moving that direction when we're going to talk about the ability to take that individualized care. And what physicians will be able to do is add context to that beyond just expertise. It's being sympathetic to what's going on in your life as a patient, you as an individual, meeting you where you live with your needs and challenges, and ask and be able to offer you therapies catered to where you are as a person. That's
Amazing.
amazing. And
Yeah.
that's what healthcare can do, right? And that's what physicians can do. And certainly, we have also, advanced practice clinicians that aid in that. The physician's assistants and nurse practitioners who are trained, but that physician training is so important because it's hard. It's not something you can gain in 2 years or 3 years. Now, that said, it also shouldn't take 15 years to get that degree of knowledge either.
Yeah, let's
But
talk about medical education innovation in a broad sense,
yeah,
like what what are the things that are being discussed now and, ch and innovation happening now that's going to, and then what's it going to look like in 20 years?
I think I think we're really at a very, very interesting fulcrum in terms of the sort of the teeter-totter where we are is we're living in trying to identify what the post-Flexner world looks like in the 21st century. Now, what does that mean for people who don't know anything about what I'm talking about? In the early part of the 1900s, medical education was all over the map.
Yeah.
You could be anybody and just throw out a shingle and say, I'm going to start teaching doctors. And it wasn't very, very rigorous. And so, as a consequence of that, there was a concern that patients were being injured. And in fact, they probably were. Um, so, what happened was there was a revolution in medical education that was basically generated by a report that came out called the Flexner Report, which basically took medical education and codified it and saying like there needs to be basic sciences, there needs to be an apprenticeship program, there needs to be a whole series of reforms that resulted in what most of us have come to know as the common medical school model, usually associated with a university or in the doctors of osteopathic medicine still often associated with an academic environment, with a very, very rigorous, and outlined form of education that would lead to good medical scientists and more than competent, but very, very high quality clinicians to treat patients. And so that's why you have, medical schools associated with the University of California, with Stanford, Loma Linda. They have these universities, University of Southern California and here in California, and also other university settings. Um, and that was great for that period of time in terms of where we were. But the modern methodologies by which that continues to work needs to be updated, and there needs to be some flexibility intoned in it for several reasons. Number one, there's a lot of redundancy. I personally, during my education, I was trained at Berkeley as a biophysicist, then went to medical school and got basic science again, and then got a bit more of it in my residency. I laugh and I say this, almost tongue in cheek, but not really. I didn't need to learn the Krebs cycle 4 times in order for me to be a good doctor. But that's what happens in the redundancy in the medical education system. And then the skill set that I did learn is rapidly evolving. Informatics in the computer industry. We didn't have computers when I first started, but now computers are really changing that. Now you have the advent of augmented intelligence and artificial intelligence being infiltrated in the medical environment. Um, just the amount of information that's now being generated is almost overwhelming for an individual to try to incorporate and assimilate into what they do. When I was in medical school, there was a book, Harrison's, textbook of internal medicine, and it was the Bible. I'm not saying Harrison's was bad, but just the ability to move beyond textbook because the information is evolving so rapidly, and being able to be a person that now knows how to take that information and apply it to the various clinical scenarios becomes incredibly important as part of ongoing medical education. And they're evolving to do that. The other challenge is an 8-year block of time for an individual to become a physician is a bit of a bottleneck, particularly when we're talking about a loss of a third of our medical workforce. So understanding methodologies by allowing us to get the same quality, high quality physicians by maybe eliminating some of the redundancy and streamlining it to be specific to what we're really looking for. Are we looking for good clinicians? Are we looking for good clinical scientists? Are we looking for, and what does that really mean in terms of how we are developing the care system, the delivery system in the aggregate? Um, and the other thing is the expense. Um,
Wow.
right now, it's, the average expense, the average debt that medical students are coming out of medical school with borders on between 190 to over 200, in some cases $300,000. To service that loan debt and be a primary care provider in an under-resourced part of the state is an enormous challenge. And putting those financial pressures on a student to say, we would love for you to be a family physician in, the high desert of San Bernardino County or Inyo County, or serving a group of individuals in Madera County or Shasta or wherever becomes increasingly challenging, because they have to look at the bottom line. Can I can I afford a home? Can I service that loan debt? Can I start a family? All those things start figuring into that equation. As a human, you're going to make that cost benefit analysis. You have to. And so identifying ways to take that cost and compressing it to a point that it's more reasonable for individuals to go into the healthcare setting as a physician.
Right.
So all of that, I think those pressures are being exerted on us. And then there's the external. There's again the pressures of where we are. We find ourselves at this moment of time where people are questioning the institutions in general. And how do we address that? And understanding that we need to be both, there's a bit of humility. I think humility is a really important thing, but curious as to why we've got to that place and figuring out how we address that path that got us here. And at the same time, reinvigorating the ability for physicians to be that trusted repository of health information, that ability to talk to people and be their friend. When you walk in the exam room, you really try hard, not only just to be someone's advocate, but to really figure out and see them, in their real life and as who they are. And that really means becoming their friend and telling them things they may not want to hear, but being honest with them and transparent in how you transmit that information. That's all part of medical education. That's all about teaching physicians that empathy. That's really what people I think are seeking in their physicians.
Well, let's talk about the project that you and I are both working on right now, which is a new program of UC Davis called Prime Central Coast, and how that is an innovative solution to the need for more medical education in the Central Coast, while, sort of the I think the opposite extreme is trying to set up an independent medical school standalone, which is really, really hard. And it's not something um, that most communities can do. You can't just pop up a medical school. But between UC Santa Cruz and UC Davis, this new Prime Central Coast is being formed. A recruitment to that program is going to start next year. The admission cycle will open next summer, and then the first class will matriculate in 2027, right? So
Right.
let's talk about that as a really concrete example of ways that medical education can be innovative, because UC Davis is in Sacramento, UC Davis Health, and their medical school. And, and it ties into this larger goal of medical schools across the country, recognizing that there's this shortage looming before us of physicians. And so they've expanded enrollment, but then that critical point of the third and fourth year rotations, core clerkships, need to happen. And so how that can marry. And just, I'd love to hear the background. I know it's been 10 years in the process, so
It has been.
been leading that. So love to
Yeah.
hear about it.
So one of the nice things about being here is we do have an adjacent University of California in Santa Cruz. And the nice thing about Santa Cruz from its very beginning is it was a university designed around innovation, trying to rethink not just medical education, but education in the aggregate. Initially, they didn't have a graded system, for example. They had narratives that were considered your grades at
Oh
UC
yeah, I
Santa
heard about
Cruz
that. Yeah.
very early on. Yeah, it's so that's kind of its base DNA, right? A place to say, like, let's think outside the box. Let's look at things differently. I would say that's probably true of Santa Cruz in general, but which makes it a very interesting and dynamic community. But they also had a program here where they were trying to educate and get folks involved in healthcare careers. Um, and that particular major has evolved. And uh, now that's being overseen by Professor Grant Hartsock at UC Santa Cruz, wonderful gentleman, and really, really interested in medical education in general, but also really what the future of medicine looks like. And if I could think of anybody who is an innovative thought leader, it's him. And so he and I have been in these conversations about figuring out how we expand medical education and what that looks like. And I was fortunate enough during my time as president-elect president and during my time at the in the executive at the California Medical Association to come in contact with various thought leaders throughout the state. That's how I met you, and individuals at the various schools of medicine throughout California. And I was fortunate enough to get in touch with Mark Service at UC Davis. And UC Davis is also very innovative.
Yeah.
They see their role as probably one of the more innovative, if not the most innovative medical school in the country with respect to developing access programs. They're very, very good at it. And they really started seeing themselves as, well, how do we expand opportunity? And in particular, the part of where UC Davis finds itself in the state, it's in this region that's abutted by areas of relative medical deserts. And I think of
I'm
the
familiar.
northern Sacramento Valley.
Yeah.
The yes, you are very familiar. Um, but I think of those communities. I think of the inland. I think of the Redwood Empire, right?
Yeah.
These regions. I think of the southern San Joaquin Valley. Again, large agriculture areas with small urban dots surrounded by massive amounts of land that are involved in raising various crops.
Or maybe the
And
mountains.
and those regions of the state, yeah, it's in mountains, exactly. And the challenges that those parts of the state are feeling with respect to having access to physicians. In some cases, there are obstetrical deserts that are popping up in these regions. I think of Madera and Madera's hospital closing because of financial issues. And now you had individuals in an entire county that did not have a hospital.
Yeah.
So Davis was looking at that and understanding that, no, we got to start thinking differently about how we do an approach medical education. And it was this, I call it an unfortunate happenstance of two things coming together at the same time with the same idea. The recognition that the Central Coast is, particularly for very, very large portions of it, having the same challenges they're having in Shasta County and in Fresno and Madera and Merced and the entire region. And so that the idea born out of that was building, having the resources with the UC here, but looking beyond the walls of the university itself and that sort of ivory covered, visualization of what college is, to realize, education's in the community. It's where people live. Again, you have to go to where people are to reach them and educate them, and also draw people out of those communities to come into the environment to go back and serve those people. And so where this all came about was that conversation came up and the opportunity to develop a rural prime program in Santa Cruz arose. Davis had been doing this all along. They had been looking to and reaching out to various areas to build medical school opportunities. And other universities are doing it too. And to be honest with you, it feels like there's a little bit of a competition between certain
It
universities in
does.
California to do that. And that's fine. This is an and conversation, not an or
It's a
conversation.
collaboration more than
Exactly.
competition. Yeah.
The more people in this particular pool, the better off we all are. And it was just fortunate enough that we were able to connect up with Davis, and the chancellor at UC Santa Cruz was all on board with this. Previously, the chancellor at UC Santa Cruz had been the provost at UC Riverside when they were building their medical program out in collaboration with UCLA. Now, UC Riverside has its own freestanding medical school.
Yeah.
And again, you're
Not
talking
strong.
about building a medical school in a region. Yeah, it's huge. A region of the state, the Inland Empire, which has the same problems in terms of recruitment, retention, and developing medical talent that large portions of the state really have also. I mean, I think of San Bernardino County. San Bernardino County, in and of itself, is larger than most states. I mean, it's massive. And so you have large areas of real estate that are, populated by these very small urban areas that need physicians. And those areas also act as magnets for people that are in the surrounding rural areas to come in and get their care. And so that idea in general, having a provost that was respectful of it, having a professor involved in the leadership structure at the university that was on board with it, and then finding the people in Davis that understood how to run medical schools, build medical schools, and develop innovative programs beyond their footprint, came together to form what is now called Rural Prime Central Coast. And I couldn't be happier. I think maybe Rural Prime Central Coast may be actually eclipse Prop 35 and one of the points of pride in my life in terms of changing a community for the good.
It should be, yeah. And I'm just so happy to be consulting at the moment, just to help connect those dots and help build the program. And in doing it, I'm amazed. There's a lot of different residents and medical students that come to the Central Coast, but the nexus is not in the Central Coast. So it's interesting to be at the very beginning of sort of building what could be someday, maybe its own medical school, but also this branch campus of UC Davis that will be the foundation for what comes next.
I think that's
Just
the
an
aspiration.
amazing work being
Yeah.
already done.
Yeah. Well, so I'm going to go and I'm going to give you a compliment now.
Okay. I like
What
compliments.
and I don't know if people on this podcast know what occurred in Chico and in Butte and Glenn County with respect to them building a psychiatry residency and the notion of understanding that we have to build our own homegrown physicians where we are. And the pressures that are existed in Butte County as a consequence of the fires and the things that occurred to that community in general, understanding that no, these people live here and they have needs that are not being addressed and not being assessed. And the way we need about doing that is we in the community, we who live here, know best what we need. And the people in Glenn County and in Butte County and that area understood they needed behavioral health, they needed psychiatrists, and they were going to build it, and they were going to build that residency program. Not only inspirational, innovative, because you did it in a way that allowed you to build it on a community-based way, focused on the community, focused on the people that live there in a way that was sensitive to the needs of that region and bringing them back. And now you have an embedded program that hopefully will serve the needs of the entire northern Sacramento Valley. And when you stop thinking about that, I go like, well, that's true in the Central Coast. We have those same pressures. My community here was devastated, large parts of our community in the north were devastated by the CZU fires in Bonnie Doon, and not just the pressure that obviously Santa Cruz didn't have the effect that they had in Santa Rosa and other places of the state with fires, but the effect of it emotionally, the effect of what went on with the people that lived here in that evacuation, the understanding that that knife's edge lives within many regions of the state now. Um, and I think about those pressures that are now being exerted. I go back to the parts of the state that could learn from what you did and what we're trying to do here, and that this model now becomes reproducible throughout the parts of the state that are seeking and needing medical expertise and medical professionals that stay in those regions. I think that Davis is working with Cal Poly Humboldt and looking at how do you build out resiliency and expansion of medical education in the Redwood Empire and in the northern parts of the state. And how do we do that in a much more granular way? And I think, to me, Prime Central Coast will be a model that will be able to teach the rest of the state how to do this, um, and how to do it in a way that leads to incredibly high quality medical professionals serving the communities that are screaming for high quality medical professionals. They're just, the need is there. It's just figuring out a way to fill the need.
Well, it's been a joy to turn my attention to the Central Coast and do this environmental scan that Grant and I have been working on, and then UCOP just gave us some more data, and then really mapping that out. So that we could see that, those core clerkships of the third year of Prime Central Coast can really be entirely in Santa Cruz, Monterey, and San Benito counties. Like it is possible, and it's really exciting. I can't wait to share our final report with the board in early October, and also I'm just going to give you a hint. I think a psychiatry residency is possible, and it's just a matter of really understanding the ACGME requirements. What would be the best sponsoring institution? Do we need to build our own sponsoring institution, which would be my recommendation, and continuing to like really make a solid Prime Central Coast from UC Davis, and at the same time go, what more could we build for a medical school beyond that? And there's so much more. I'm going to be in Santa Cruz next week. It looks like Hartnell College has an amazing sim center, and I'm so excited to go check that out. I hope I can get there next week. If not, it'll be when I'm back in the Central Coast, probably in November. But uh, there's a UC Santa Cruz launched their post-bac program too, which is an incredible way for local folks to, get the requirements that are needed to go into medical school. And then, sort of that pathway, it kind of opens that door and helps them take that a really big step from undergraduate into medical school. So it's exciting to see all that can happen.
Those sort of programs are actually really important because not everybody comes right out of high school knowing they want to be a physician.
Right.
And there are people that have a journey in life, right, that get them to a point where they go like, looking back on it, I wanted to be, I want to be a physician. I think I feel the call to do that. And so having the ability to go back and do that reset to allow themselves to now be eligible to negotiate the curriculum of a medical school education becomes incredibly important. You also pointed out something I think that is really important, that is partnering with other local institutions that are here. And so the community colleges, particularly for under-resourced individuals, becomes an important part of that, and making sure that the curriculum will translate into medical education in a way that does it seamlessly. Again, we're talking about cost. A lot cheaper for somebody to go to Hartnell or Monterey Peninsula College, Gavilan College, or Cabrillo, and then take what courses they need to at the university level, or even thinking that further through, what about a 6-year education that goes from bachelor's to MD and compresses the entire thing? And it's done in a way that is woven within those educational opportunities with partnerships that you have with other community members. We could do that. There's anatomy is anatomy is anatomy. The spleen hasn't moved. It's the same spleen. It's
No.
just making sure that the right. But where you learn that and with what rigor you learn that in order for you to be a high quality physician makes sense. But if you take that and translate and say, no, this is the level with which we need this taught at, I have been astounded with the ability for community colleges to meet that challenge and be able to say, we got it. This is the mark you need to meet. We'll get there. We'll figure out how to get our abilities with both our instructors and the way we teach the course. And a lot of that's also being done virtually now and online. So it's, the old days where you went to a lab with a cadaver and, teased out every nerve or teased out every tendon, really isn't the way people learn these days. And to back to your point about sim labs, the ability to reproduce a clinical environment or clinical experience in a place where in a community where people live, and then have that information tie in terms of where they need a bit more education or where they've reached a level of accomplishment that allows them to move on to the next level becomes also really, really important. But also something I think is incredibly important about that is the ability for those those community-based educational opportunities to reach further down or further upstream to kids in junior high school and kids that are in high school, and get them involved and get them in trained with either regional opportunity, ROP programs or other methodologies which allow them to really start understanding what healthcare careers are about at a very early point where they start making these decisions, and and
As early
and
as
really
seven,
outreach.
age seven.
Yeah.
But
Well, think
also to
about this. So
have,
you come from a family that
oh, just I wanted to say that just to have medical education in your backyard and in your area, in your town, and to know that somebody went through that program and is now becoming a doctor. Those are things that they're just like so valuable. It's hard to put into words sometimes how important it is to have that education pathway in your area.
and sell it in such a way that say, no, it's possible for you. This is not unattainable.
Yeah.
Part of the problem with a lot of the traditional, under-resourced communities, it feels unattainable to them.
Right.
And that needs to go away. There needs to be an elimination of this veil of unattainability that my parents were farm workers or my parents were day laborers or in the construction business. And while we need that, trust me, believe me, the trades are absolutely important. We definitely need physicians as well. And so having someone in that family realize, hey, I can this isn't necessarily a pathway that I have to follow that my family's followed. I may be able to move into this pathway and do something different. And 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 so allowing that ability for that sense that there's an elitism that people feel with medical education that
True.
needs to go away.
Yeah.
And it's not. It's just it's you got to work hard. There's nothing elite about me. Trust me. The last person you would ever look at and say, elite is me. I'm not that individual, but I work hard, and I understand the value of hard work, and giving opportunities to
Yeah.
people similar to the opportunities I had. I was educated before I went to Berkeley at a community college because I couldn't afford going to Berkeley right out the gate. No way. That was an opportunity. It was given to me and I took it. And when I got to Berkeley, I did make the most of it. And the same thing at UC San Diego. I'm not unique. I'm the product of training and opportunity. And I think that's true of pretty much every kid in the state of California who wants to become a physician. Give them opportunity, understand and tell them this is not going to be an easy course. It's not, unicorns, rainbows, and chocolate fountains. That's not what it is. It's hard work, and there's going to be, failure, but there's also going to be tremendous success. And at the end of the day, when you sit in a room and you actually can look at somebody that's better off because you helped them, or someone that's alive that wouldn't be alive because you weren't there to keep them alive and do the thing that you do, or a baby being born and you were part of that baby's good health being brought into the world. Or in the case of somebody that's suffering and hurting because of something that traumatic that happened, and you were in the room and you listened to them and you provided them care. There's nothing in the world that's better than that. Absolutely nothing. And
Well,
that should be able
thank
to cover everybody in the state.
As always, I really enjoy talking with you, and so glad that you could be my first podcast. So thank you. Is there anything else that you would want to add to this discussion, or we covered a lot, I
Yeah.
think.
Yeah. I think medical education is going to evolve. It has to. And there are people that are worried about that. And I want to reassure them that we want high quality physicians. The state patients, communities deserve high quality physicians. But you just have to figure out a way to maintain the high quality and ethical practice while at the same time realizing these challenges exist before us. And smart people put together who really want to make change, make great things happen. And it's not just going to be within the medical community and the educational community, but it's going to be elected leaders working with us. It's going to be, you know, chambers of commerce understanding the value of it. It's going to be people in the ag community or other labor unions throughout the state that understand, no, this is important for all of us. And eliminating multi-tiered healthcare delivery in a way that every Californian can be assured of high quality healthcare no matter where they live and no matter what their situation is in life. That I think to me is the ideal, and we'll get there, all of us together.
Thank you so much for that vision. Yeah, I agree. It's possible. And I think having done what I did in the northern part of the state, developing a psychiatry residency and a family medicine residency when I was told it wasn't possible, I think there's ways to make these things happen, and I think all of us working together will make it true. Thank you so
I,
much, Dr. Hernandez. I'll see you next week, I hope.
I absolutely, I'll be here.
Okay,
Thank you.
bye.
Take care.